Okay, good afternoon everyone and welcome to this month's webinar. Today's topic is integrated approaches to volunteering. We're really glad you could join us. We've got a lot of new members this month, so special welcome to you all. Hope you enjoy the webinar. We are going to be recording it, so we'll send the link round within the next few days. You'll be able to watch at your leisure. So today we've got two very special guests. We've got Paddy, who many of you will know, but if you don't, this is Paddy Hanrahan, who's our Director of Strategy and Innovation at Helpforce. And then our VIP guest today is Chris Easton. He's Head of Person and Community Centred Approaches at Tameside and Glossop Integrated Care NHS Foundation Trust. So we'll be welcoming Chris shortly. So to begin with, I'd like to introduce Paddy, who is going to talk about the integrated care programme that we're working on currently.
Thanks, Sal. Yeah, so today's webinar is the first webinar where we brought together our long-standing network of trust-based volunteer managers and stakeholders, along with our more new set of community guys, which is the system stakeholders, so the STP Integrated Care System project. And given that the two audiences are mixed, we had a request that we could talk and introduce a little bit about what that new programme is, which is what I'm going to do now. So the Volunteer Integrated Approaches programme started in September last year. Could you move on a slide for a second? Yeah.
Bear with us.
So we're just trying to get the slide to move on. Hopefully everyone can see that now. Just a bit of info on the programme. The programme started back in September. So it's an NHS England programme that's been offered to all systems. So we call it kind of shorthand for STPs, integrated care systems. And the aim is to embed volunteering in plans for integrated care. So what was fantastic with the publication of the long-term plan was the inclusion of volunteering in there. And what we're trying to do now is work with leaders from, as you can see there, 39 of the 42 systems to essentially try and embed volunteering into their plans at this early stage. So it's a fantastic opportunity to try and recognise a lot of the volunteering that's happening out there, but trying to bring it together into an integrated approach such that it's looked at more holistically. The role for Helpforce in that is that as national delivery partner, the key thing this year is about trying to form a network. So we brought people into a kind of community to try and support with their planning and their design of their projects, but more crucially such that we can work together as a community to try and help each other, try and rise the tide of volunteering over the next 2 to 3 years. And the shape of the kind of programme is that this year, a lot of the systems are doing great work to try and better understand all the different types of volunteering that's happening out there across patient pathways, so what's happening out in communities, around primary care, into trusts, and back into home. And in the next couple of years, what we'll be doing is supporting a number of projects with trying to evaluate the impact in the interest of eventually trying to spread really good practice and innovation around volunteering into the integrated care system. Another key thing we're trying to help with this year, and we'll be addressing in a couple of events that we do next week, is trying to build what we're calling the leadership case. So trying to essentially help convince all system leaders and key system stakeholders of the real value of volunteering and the potential of volunteering to not only address a number of kind of priorities in the long-term plan and in local system priorities, but also to try and recognise that by bringing together NHS organisations, local authorities and the voluntary sector, that we really can maximise the impact that volunteers have. And crucially, the fact that volunteers are already helping with integration between different organisations. I will not say too much more because we all want to hear from Chris. The slide here, a lot of people have seen from our integrated care community. This is on our learning zone, but I think what we was trying to do when we first formed this programme was to say that, yeah, you know, we all share an ambition. It's very exciting about how volunteers can play a much greater role in integration. But actually, one of the interesting arguments I put across to a lot of system leaders is that volunteers are already an enabler of integration today. So what this diagram shows is just a small subset of examples of volunteering initiatives that are happening across the patient pathway, out in the community, around GP practices, into hospitals, around hospitals, and then people helping people get home. And with examples like practice champions, where they're helping to reduce A&E attendances, or with things like hospital to home, which are keeping people home and out of hospital. There's a strong argument that volunteering is already helping with integration. And I know this is a point that NHS England leadership are quite keen on. I think that the opportunity is the fact that these are all very, very sporadic in terms of how they're implemented. And if we can get integrated care systems and thinking about how we can try to get all of these volunteer opportunities working in pretty much every system, then there's a huge opportunity. And what we're trying to argue through the leadership case work is that there is tangible value that can be realised for a fairly modest investment in volunteering. Volunteering is not free, it does cost money, but when done well, it's a modest investment and huge potential for return. So that just a bit of information about the programme, to set the context.
Brilliant, thanks Paddy. So I'm going to hand over to Chris now, just as a bit of background. Chris leads transformation programmes across the Tameside and Glossop area, specifically focusing on how to create new relationships between health and care and the public, and moving towards empowered communities and people who are actively more involved in their own health and care. So welcome Chris, thanks for joining us, and hope everyone enjoys Chris's presentation.
Thank you. So can you see my screen just before we start? You're able to see my slides now?
Yes, thank you.
Brilliant. Okay, well thank you. My name's Chris Easton. I work for Tameside and Glossop Integrated Care Foundation Trust, and my role is principally about designing new ways of delivering health and care that work in much more person-centred and community-centred ways. So over the past 3 years, we've delivered a whole range of different programs, but the one that I'm going to talk to you about is something we call wellbeing in practice, which is an improvement model that we've developed in collaboration with our GPs and people working in primary care, in order to solve some of the problems that general practice faces. So wellbeing in practice is a coordinated program of support. We support practices to connect better with their local community, unlock the assets that communities provide. We help them to adapt to the demands of their local population. I think one of the challenges we all recognise in general practice is that a significant percentage of the demand is potentially avoidable, and we help them to respond to some of that. We're really keen on shifting the emphasis of general practice away from a place where people go purely to be treated when they're ill, and towards something that people go to when they also want to remain well, and a place that sits at the heart of people's communities. We do a lot of work to tap into community assets and the power of people, and we embed social prescribing and other responses to people's health needs that deal with social context and wider determinants of health. So this is a little bit what our model looks like. We go through a journey of insight, co-design, implementation and evaluation. I won't dwell too much on that, because actually the bit that I want to talk to you about in particular is how our practices are engaging differently with their communities. But critically, my team provides coaching support to every practice involved in the programme to guide them through the process. We don't do very much for them, but we help them solve the problems that they face. So just to start off with, I thought it was worth reflecting on why we need to change. And many of you will have seen this sort of slide before, but I think it sits right at the heart of sometimes what we do wrong when we're trying to transform health services. And this is an infographic developed by the Health Foundation, which really highlights that as little as 10% of the things that keep us healthy are in any way linked directly to the provision of healthcare. Yet when we try and solve many of the problems that healthcare faces, we try and change the system, and we try and change the way we try and do the things that we do sometimes better. Our challenge is that sometimes we need to do better things instead, and look very differently at the problems that we face. But certainly at the heart of a response to the challenges that the health and care system face is a response to the wider determinants of health. It's also interesting to think about what our expectations are. What do we as the public expect from our health and care system? And over time, we've become very used to, in the very most part, becoming passive receivers of healthcare. We go into the healthcare system at a point where we're experiencing ill health, and we hope that the system will respond to that. But the interesting thing is that patients, members of the public, routinely overestimate the benefits of treatment and routinely underestimate the potential harms. And added to that, medics do exactly the same. So we're creating a system whereby potentially we're over-treating people, potentially we're even harming people. But what it really highlights is that we have an over-reliance on biomedical models of care. There's also a disconnect between how we see ourselves and how clinicians see us, particularly when we experience long-term conditions. So the word clouds that hopefully you can see in front of you, on the left we have the sort of words that clinicians would associate with patients. So arthritis, COPD, diabetes, depression, all very condition-related descriptors of people and of their work. By contrast, the public, when talking about long-term conditions, we're talking about loneliness, identity, loss, fear, grief, hope. We need to bring these two things together if we're genuinely going to respond to people's needs. So at the start of our model, we go into a practice and we've developed tools that help them think about the nature of their demand. I'm going to run you through some of the things that we look at. It's much more in depth than this, but it kind of gives some useful context and some ideas as to how we might start to work a little bit differently. So this slide looks, and this relates to one practice. We analysed 262 consultations over the course of a week in this particular practice, and asked the GPs to think about whether the person in front of them, whether that appointment was as a direct result of what we would categorise as failure demand. So that's an appointment that is caused exclusively by failings elsewhere in the practice, or potentially the wider health and care system, rather than the person's original need. Now we've done this at about half a dozen practices so far, and this percentage of 16 to 20% failure demand is not unusual. So we're potentially saying that 20% of the demand created in general practice is as a direct result of failure elsewhere in the system. We also asked them to look at life context. So this is thinking about the extent to which an individual's life context may limit their ability to respond to the type of interventions we traditionally provide as a health and care system. So again, in this practice, over 20% of all patients, just under 25 in fact, the GPs were categorising as having life context that was either under pressure or turbulent. And that in turn, that's likely to have an impact on their ability to manage a long-term condition or to respond to the advice that they're being given. And of course, if we think about it, that makes real sense, doesn't it? Because if you have a difficult life context and you perhaps don't have a job, you don't have very much money, you're lonely or isolated, then it stands to reason that health drops down your priority list when it comes to the things that occupy you on a daily basis. GPs also thought that 21% of all the patients they saw in this particular week required a response that helped them with that life context, rather than just a linear biomedical response. When we dug into this further, GPs' enduring frustration is that they don't have a sufficient number of those responses available to them to be able to respond in that way. In this particular practice, and this is slightly lower than many of them, 53% of the presenting patients had one or more long-term conditions. Some, it was as high as 70. And we asked GPs to think about whether or not the needs of those individuals are likely to increase, and whether that increase is likely to be beyond unavoidable disease progression. And in 30% of that 50% of appointments, so in this practice's case, 15% of their entire caseload in a week, they believed that that people's condition was going to physically decline for a reason other than natural disease progression. And I think this is really interesting because at best it says we're not meeting people's needs appropriately, and at worst it says potentially the way the system is operating is actually potentially harming people by not meeting need. So we really need to think very carefully about how we respond, particularly in the case of people with long-term conditions. What was interesting, I haven't got this slide here, but what was interesting, when you map across the cohort of people we were talking about on the previous slide, the under pressure and turbulent, they map very, very closely to that 30%, which really highlights and emphasises the importance of social context, the importance of wider determinants of health when it comes to delivering good health outcomes for people. So we move on to then a phase of working with practices and communities together, and the slides and many more slides actually that on top of those and a much broader bit of insight work gives us the framing for that and allows us to tell a story of the practice. So we start by sending a text to all the patients on the practice list, and we invite them to play a role in improving the health and well-being of their communities. And I was deeply skeptical at this point in the process that we would do this and we'd get no responses back. We've just done it for one of our practices in the past week, and I can assure you by the busyness of one of my team, we definitely get responses. One practice had 196 replies in the first 4 hours. We then speak to all of those people, or those that want to take it to the next stage, and then we invite them to a workshop with their practice. And that workshop is very broad. The whole practice team join it along with members of the community, and we talk about the sorts of challenges that the community and the practice have. And very often they're similar challenges presented through a slightly different lens. The practice and the community then come together and they collaborate around developing a suite of solutions that address some of those problems. Now, some of those might be straightforward kind of community-based things where, I don't know, for example, people maybe need to get more physically active. So we've got walking groups going on all over Tameside and Glossop. We have Tai Chi going on in waiting rooms. It might be that the practice want to do more group-based peer support for people. So we've had co-delivered sessions and peer support groups between a clinician and a patient looking at living with depression and mental health. Or it might be that the practice need particular help in an area where they're struggling. So we had one practice where the waiting time to get through on the phone was 45 minutes. The receptionist came together with some of the people who came to the workshop, and they designed a suite of solutions and have reduced that to a 4 or 5 minute wait by reducing pressure on reception. One of the things I should just mention, I should have mentioned right at the beginning, we rarely use the word volunteering. We do at times because people understand what it means, but to me volunteering is something where we have a job that we're asking people to volunteer to do for us. This is much more collaborative than that. So we tend to refer to it locally as collaborative practice, and we refer to our volunteers as practice health champions. They're part of the practice in just the same way as a GP or a practice nurse or a receptionist is. And so then this journey begins, and we have this new sense of collaboration. The picture you can see in front of you is from one of our practices who actually struggled in the first instance to recruit any volunteers at all. And they discovered the reason they struggled was because actually they had a really poor relationship with their community for whatever reason, and there were a number of local challenges, and that just galvanized the practice into really wanting to to alter that, and so they made dozens and dozens of luggage tags, attached them to apples, and delivered them around their community, inviting people to participate and having new conversations with people. They now have a really incredibly vibrant program, and they had to move their Christmas party last year into a bigger room to accommodate the number of members of the community who came. So key features of the volunteering approach. Volunteering is a little bit misleading, as I've just said. The model relies fundamentally on authentic collaboration between the community and the practice. Without that, it doesn't work. This isn't something we do to or for practices. This is something they need to own. The resulting practice champions become part of the practice. They're just as important as paid employees. And importantly, we don't start really with a defined idea of what they will do. We look at what they bring, what excites them, what they think they can offer. Of course, now we've got lots of examples of different things people are doing that can act as a source of inspiration, but we don't try and prejudge what people might do in the practices. This slide, which I won't run through in detail, you'll be able to see this on the slides that are shared subsequently or on the recording. Just gives you a bit of a flavour of the journey that we take practices on, and at numbers 4 and 5 is where members of the public really get heavily involved in the process. So this programme is active in 9 of our 37 practices. In the past couple of weeks, the CCG have asked us to roll out with all 37 practices or to really start the rollout between now and March. That's incredibly challenging, but really gives a sign of how committed both the CCG in our area and also the practices themselves are to engaging with the public differently. We've got well over 100 people now gifting their time to work alongside their practice. Each practice creates a staff circle to support the work of the champions. So we don't end up with one person being responsible for this. It has to be something that really sits within the kind of the way the practice operates. We have tens, probably dozens of activities now taking place across Tameside and Glossop on a regular basis. And we've made funding available to champion groups to support their activities through a wider strand of work we have around asset-based community development. And they go off in a whole range of different directions. So one group, for example, now has actually constituted or is in the process of constituting as an organisation in their own right, so they can attract their own funds into the practice, into the community, to expand the scope of what they're doing. Interestingly, in that particular practice, we talk a lot about social prescribing in health policy at the moment. This connects really closely to it. The referrals from that practice into social prescribing have gone down in number but up in complexity. And the reason for that is that they are now signposting people to the activities run by the champions in their communities, which in my mind is much more organic and natural than a referral into a social prescribing service, and certainly where we see our social prescribing going in the future. So just to tie this up, in terms of key learning, we've always been pretty clear, I think, in Tameside and Glossop, that the answer to many of the health and wellbeing challenges our community faces lies not in health and care services, not in the public sector, but in communities ourselves. And to that extent, it's really beholden on us as public sector providers to find ways of harnessing those assets, and that means that we need to work quite differently with people. We need to engage differently with people, communities, community organisations, and treat them as equal, not as recipients, engendering a sense of collaboration. Now, sometimes that's difficult in the public sector because we're used to doing things in particular ways. We're used to commissioning services in particular ways, but we have to make that leap. And that was difficult for us in the early stages when we had a series of transformation programs that were built with significant capacity to be able to measure and count impact. Yet when you're talking about lots of this stuff that happens very organically in communities, we have to believe that it works, and we have to capitalise on the ways in which we can evidence impact without ruining the whole thing by trying to monitor it to death. It's challenging to do things differently in a system under pressure, but the rewards are often worth it. Almost with every practice, we were challenged on whether or not they had time to do it, and almost without exception, in every practice, they found the time and certainly didn't regret it, and that continues now. Context is really important, and we've spoken about this a lot locally and with other partners. This sits at the heart of a much bigger personalised care programme in Tameside and Glossop that looks at a whole suite of things, from wider determinants of health to managing long-term conditions differently to organisational development. If you don't have organisations who authentically believe and value personalised care, new relationships with people and communities, then I suspect very strongly that this kind of intervention is very, very tricky, and that has to run through right from the top of organisations. One of the things that never ceases to amaze me is just how generous people are. As I mentioned before, I think when we sent out the text to practice lists, I was worried that we wouldn't get engagement, but people care really deeply about their communities and the well-being of their communities. Often there are people who want to do really significant things but don't have a framework within which to do that stuff. We can harness that if we create space for this kind of collaboration. And I think if I were to speak to any of our practices now, they would view this now as an integral part of what they do. And in that sense, it's been an incredibly powerful journey for us. So I hope that was okay. A really brief, I think probably 15-minute race through of what's quite a complicated 2-year programme of work. But I think we're going to move on to questions.
Thank you, Chris. It's really great to hear the progress you've made. It's inspiring stuff, and I'm sure it's generated a lot of ideas and creative thinking for people. We've got a few questions coming in. I'm going to start with it's quite a lengthy one, so forgive me while I just read out the summary of it. It's from Candice, who's at Humber Coast and Vale STP. The voluntary sector has focused on people empowerment for over a decade now and has been at the forefront of putting this philosophy into practice. However, the cultures of the NHS and voluntary sector are currently worlds apart. For example, the NHS still regularly refers to people as patients and seems unable to move away from this. Chris, what are your views on the clash of cultures here, and how could this be overcome, do you think?
Okay, so clash of cultures between the voluntary sector and the public sector. I think first and foremost, it's worth reinforcing one of the points in that question, that you're right. The voluntary sector has been doing this stuff for years. I spoke last year at a social prescribing conference for the voluntary sector, and pretty much opened up with that. The voluntary sector must get really irritated with the way in which health in particular has created this thing that they call social prescribing. And in reality, the voluntary sector has been doing that for all of time. They just haven't received the kind of recognition that we currently have in health policy for it. And we need to be very conscious of that. I don't think the culture difference is as stark as we might believe when we get back to why people do what they do. You know, the vast majority of people work in the public sector because they want to improve the lives of people. The vast majority of people work in the voluntary sector because they want to do exactly the same. And so when you're talking at a relationship level, we're not very far apart. I think when we look at a policy level, things get rather more complicated, and we get mired in the complexity of language. You know, I would love us never to refer to people as patients, but you know, that's going to be a challenging thing for the system to do, especially when you look into the origins of the word patient, which come from you know, being around passive and passive receivers of things. It feels wrong in the current policy context we have, but to some extent with language we are where we are. I think the place to really focus attention is on relationships. We have a really strong relationship with our voluntary sector, and I believe that's because they feel trusted. We've invested in them. We give them as longer term contracts as possibly can. They have a seat at the table, and I like to think we treat them as equals. And that's gone an awful long way. It hasn't always been that way, But I think at the heart of it are relationships, and when you get to that stage, in honesty, people aren't all that different.
That's brilliant, thank you. We've got a question from Emma. Emma's asking, how does this project link in with priorities for primary care networks?
So interestingly, a lot of the priorities of primary care networks, particularly around things like social prescribing and the wider determinants of health, we've been doing in Tameside and Glossop for nearly 3 years now. So we've almost had to retrofit primary care networks into models we already had established around integration and social prescribing, to the extent that primary care networks should have an emphasis on population health, it should have an emphasis on engaging with communities, and definitely has very clear priorities around social prescribing, then this project links and connects directly with it. Also, if you accept that a key priority of primary care networks is managing demand in general practice, then this can play a really significant part in that respect too.
Real, thank you. We've got one from Mark now. How did practices create an environment where patients felt safe to give what might be considered negative feedback on the support and care they may have been receiving?
Okay, right. So there's probably a couple of parts to this. So I should probably mention at the beginning that Tameside and Glossop is an area just on the edge of Manchester, and typically folk around here aren't particularly shy in giving feedback. It's not something we've ever particularly come across as a problem, because we brought people together in a collaborative way for this conversation. You often can't tell who does what. You know, the GPs don't come dressed as GPs with badges on. They come into the room and have a chat with people, and very often people who work within practices have quite challenging feedback to give, and what we found was that very often the kind of negative feedback that members of the public were given were almost mirrored by a negative experience on the part of a practice in some way, shape or form. So if people complaining, for example, about the fact that it takes half an hour to get through on phones and then they can never get an appointment, the receptionist is saying, well, actually people are queuing out the door at 8 o'clock in the morning, and the phones are ringing off the hook and this and that and the other. And we're presenting the same problem from two different lenses. In that particular example, two members of the community said that they would be really interested in coming in several mornings a week to teach people how to use the check-in screens, to reduce those queues and take pressure off the receptionist. So I don't think usually people who work in practices are in any way blind to the kind of feedback they'd receive, and we've not really encountered that as a problem, I don't think.
Lovely, thanks. Yvonne's asking why exercise doesn't seem to be included within the framework. So
I'm not completely clear what framework we're talking about, but in terms of this program, exercise is one of the things that is often one of the byproducts that happens when people come together. So as I mentioned earlier on, we've got Tai Chi sessions in waiting rooms. We had one person who volunteered coming forward who ran a chain of gyms and started to give access to people with long-term conditions. We have endless walking groups going on around the locality, some linked to issues like people with respiratory conditions, some just orientated around getting people out and responding to loneliness. So exercise forms a really big part of what we offer. But if Yvonne wants to email me with some further clarification, I suspect I probably haven't answered that question quite right, then I'm quite happy to give a more detailed answer.
Brilliant, thank you. Sheena's asking, has a multidisciplinary team approach been adopted through risk stratification of patients?
Yes.
Okay.
Yeah, we have MDTs in all of our localities, both around long-term conditions and people who are risk stratified, but also around particular areas of priority such as frailty.
Great, thank you. Heather's interested to know where the leads for collaboration are recruited from. Heather's a community development officer and she hasn't met many people with that skill set or experience, so she's wondering where they come from.
So again, I'm slightly unclear what we mean when we're talking about the leads for collaboration, so I'll respond to this in a couple of different ways. So I'm very fortunate that I have a team of people who have exactly those sets of skills and experience. And we've very deliberately tried to step outside the traditional mould of NHS recruitment in order to attract some of those people. Also, we ask the voluntary sector to deliver a lot of stuff with us or on our behalf, and very often the voluntary sector is flooded with people who have this kind of community development expertise. And then finally, within the practice, often we don't know what skills people have or where their interests are, and it's unusual for us to go into a practice and not identify somebody who really connects with this in a very significant way, and then we work alongside them to set up the structures to allow them to lead this work within the practice.
Great, thank you. And we've got another question, one from Philip. How much was the local volunteer centre and/or CVS involved and engaged with the work? And did any funding come through to them, as this type of work is what they're all about?
So in one of our localities, our volunteer centre delivered this work. In the other 4, it was delivered from within by a member of staff within the NHS. Now, interestingly, that's quite unusual for us. So we invest currently around about just over £1 million a year in our 2 voluntary sector providers or infrastructure providers to deliver social prescribing and asset-based community development. This particular piece of work, we wanted to really connect with them in delivering it, but wanted to hold some of it within my team. But yes, we do invest very significantly in those organisations. We've also created a very significant funding pot to fund grassroots delivery voluntary sector organisations too. So when you talk about things like social prescribing and other models of delivery, one of the things we often miss out is that it relies fundamentally on what are very often very small voluntary sector providers. And we made a commitment from the beginning that we wanted to make sure that we resourced those organisations if we were going to put capacity pressure on them.
Great, thanks. Mandy is wondering about the responses from the community. Were the majority of responses from the well members of the community?
To be honest, I'm not entirely sure we would always know, because we don't ask. It's not something that's particularly important, but there are. It's not important in the sense of it's not something we would measure. It is important that we reach as many people as possible. What I can say is there's a real diversity around the people who are coming forwards. And I also know of a number of very specific examples where there have been people who've had experienced particular ill health who have come forwards to be involved, and also people who've experienced some really challenging life circumstances. In first practice we worked with, we had very few volunteers initially, and one of the people who came along was a young woman who'd been in and out of drug and alcohol services, had a long history with social care, had children taken into care in the past, and she came in to get involved, and her opening line was, I can't think of anybody better to help people like me than somebody like me. And of course that's absolutely right. You know, who are we as you know, in inverted commas, professionals in the system to assume that we're the best people to help people who experience particular challenges. And it was just a really good lesson early on around how, if we can identify people with lived experience of particular situations, how we can harness or work with people to harness and develop that, and to support people in a way that we couldn't possibly hope to. The same applies with a group that was set up in one of our localities around support for people experiencing bereavement. There was no provision locally. It was set up by somebody who had recently been bereaved, and it grew dramatically. In that instance, interestingly, professionals were invited into that space latterly, because they recognised they needed some professional support with people, but actually it was very community driven, and there are lots of examples from in relation to that.
Great, thank you. Mandy's had a 2 for 1 because she's also asked, what were the general demographics of the volunteers? For example, young or retired or working at home. Is that something that has been measured?
It's not something that we've captured in a way that we could analyse, but I've sat in all the rooms with the groups of volunteers, and I think my assumption initially was that we would end up with a dominantly older retired cohort. It just simply isn't the case. I mean, there is a time commitment involved, so invariably they are people who have time. But actually, one of the really nice things about this is because we're not saying we want you to volunteer to do this particular job with this particular time commitment, we're saying we want you to come and talk to us about how we can work together to improve the health and well-being of communities. But that can happen in a whole range of different ways. So for the person I was talking about before who ran the chain of gyms, I suspect is an extremely busy person, but found a way nonetheless to put something back into their community. We have people who work in welfare rights who wanted to give something back and ran clinics in a GP practice around supporting people with welfare and benefits and that kind of thing. So so it's mixed. I mean, I would be lying if I said it didn't have a probably higher percentage of older people, but also I'm pleasantly surprised by the number of younger people who are involved as well.
Could I ask a question, Sam?
Yeah,
Hi, Chris. You mentioned earlier about how you've got the support. I guess you mentioned kind of top down. So I guess from the PCN level down to the practices, clinical director down to practice managers, GPs. Has there been a particular group that's been harder to win over? Because it's quite a revolutionary concept. Has there been people that have been more harder to win over in making this happen?
So in any group, there are inevitably going to be some people who are more difficult to engage, but I don't think you could categorise them as a cohort of people. So within GPs, 3 years ago, when we were trying to generate interest in this kind of work, I would go to meetings and with some receive quite hostile responses. And I think the view we took at that time was, well, do you know what? That's okay. We'll work with the enthusiasts. We'll influence the people who are on the fence, and then the people who are totally disinterested at this point will come along eventually, and usually they have. Actually, we started this way before PCNs were even conceived as a concept, and so as a result, we've really been able to influence lots of the work that has gone on at even a higher level than that. So the chief exec of our strategic commissioning function, which is the local authority and the CCG combined, has been incredibly supportive. The chief exec of our hospital or integrated care trust, likewise, and even at a Greater Manchester level, because we have devolved health and care funding. Lots of the work the Greater Manchester Health and Care Partnership are leading in a policy sense has taken a lot from the work that we've done in Tameside and Glossop. So that the strategic framework is there for this to happen and to be successful.
That's really helpful.
We've got one more question, I think, that we can squeeze in. Jane has asked, can you see this model working in hospitals?
Yes, absolutely. And I think it's a more challenging proposition because it's a much bigger thing to tackle. But if we go back to the insight piece, what I don't want to do is just lift and shift a model and move it elsewhere. I'm not sure it transposes directly like that, because actually some of the problems we experience in hospitals are different. But if we go back to the insight piece, I'm really interested in developing the tools that we've created. So in general practice, we ask questions like, why is the person in front of you here? Is it social context? Is what have you? We can do exactly the same exercise in the emergency department very easily. If we go into our ED, typically people would say 40% of people who come through the doors of emergency department don't need to come to emergency department. But yet we don't really understand genuinely why they're there and what that looks like. So we could do some really useful analysis there. And similarly on a ward level, you know, you could ask questions around why is somebody in this bed today? You know, having had recent experience of a family member in hospital, there were multiple days where that person didn't necessarily need to be in a hospital. And I think it's a useful reflective tool to encourage people to really think about how on every single day of somebody's care we're moving them more forwards to where they need to be. So absolutely it could transpose. And the principles as well, the principles of you know, collaboration rather than volunteering. There's no reason that those things can't work. It's worth I've just opened the chat box as well. I think there's a question that's snuck into there around collaboration and co-production versus engagement, and whether or not we provided additional training to people. We didn't actually. We talked to people about what we wanted to achieve and what that looked like, and then we just, broadly speaking, spoke to them differently, and engaged them to a point where we didn't have a solution in our head. We had a series of problems that we shared, and I think that leads quite organically to co-productive, collaborative approaches.
Chris, I just want to thank you for your time today, but also your enthusiasm and your ideas, and just being really great to listen to. So thank you for joining us. We've been really really delighted that you were able to, and I hope that everybody's learnt a lot from today's session. Chris, will it be okay if we get any questions coming in after? Can we forward them to you?
Of course you can. I'm very happy for the slides to be shared as well, and my contact details are on the final slide of the slide deck.
Brilliant. Thanks so much.
Thank you very much.
Thanks for joining us, everyone. It's been great to have you all online today. Just to let you know that next month's webinar will be on the 27th of Feb, and our topic will be end-of-life care. So I hope you'll be able to join us then, and we'll send more details in due course. But for now, thanks for joining us, and hope to see you all soon.